So this is our second session, and the purpose of these sessions is to provide guidance on how to treat our patients and our colleagues and gain leadership skills throughout our emergency medicine career. We didn't want it only to be about clinical skills and taking care of patients. We wanted you to be able to learn about different things that can enhance your career no matter where you may be, and talk about things outside the bedside of medicine. Our first talk was by Dr. James Pruden, and it was very inspirational, talking about what he learned himself as a clinician and as a patient suffering through COVID-19. And today we're going to have Dr. Al Sacchetti present to us about community emergency department research.
All right.
I'm going to do your bio, Al.
Oh, no. All right, go ahead.
Yes. Okay. Dr. Alfred Sacchetti is the Director of Clinical Services in the Department of Emergency Medicine at Virtua Our Lady of Lourdes Hospital in Camden, New Jersey, and Assistant Clinical Professor of Emergency Medicine at Thomas Jefferson University in Philadelphia. A full-time clinician, he is also a dedicated researcher and enthusiastic educator with over 100 journal publications and textbook chapters to his credit, and more than 1,000 national and international lectures. Dr. Sacchetti's recognitions include the Maternal and Child Health's Emergency Medical Services for Children Policy Leader of Distinction Award, the American College of Emergency Physicians Lifetime Commitment to Communication Award, the American Academy of Pediatrics Martha Boucher Fallis Award for contributions to advanced pediatric life support, and the Emergency Medicine Review and Perspective Challenge coin for his humanitarian commitment to emergency medicine. My friend, Dr. Al Sacchetti.
Thank you, Janice. I have to say, Janice wrote one of the most complimentary articles ever, but when she talked about our relationship. And I have to say, I've got that set aside. And pretty much anytime my wife gives me grief, I just pull this out and I say, you know, Janice would have me come and stay with her at any time now.
And I'm that block, so it's true.
Yeah. Unfortunately, my wife packs the suitcase at that point. So, but yeah, Janice and I have gone back quite a ways. And I will tell you, as I was the director at the time when we interviewed Janice, and Dr. Russ Harris and I went to lunch with her, and we said goodbye, and she got in her car to go. He looked at me and he said, "We got to get this person." And we did. And it was just all uphill from there. It was just great. And she is probably, keep an eye on her. She will be president of ACEP within the next couple of years. So she is somebody, if you really want to learn how to move in your career, but at the same time earn the respect of all your patients and your administrators, talk to Janice. She's the one who can help you with that. That said, I'm going to tell you something that may or may not help you. We're going to talk about doing some research, and I'm going to try and share the screen. So let's see what happens. If I do that, aha, that shows up. And if I do that, more thing. Janice, are you seeing the slides now?
Yes, we can see the slides.
Okay. We're going to talk about a little bit emergency department research in the community hospital setting. Those of you who are working at university centers already know about this. You've got a dedicated research director or two. You've got grant people coming in, and you're all involved in multiple different prospective studies and device and drug research. But one of the questions is there any value doing this in the emergency department setting in the community hospital? And there's a couple reasons to do it there, and obviously I've taken a liking to it. But this is, if you look at it, let's see if I can get the slide to change. Nope. Let's try one more time. There we go. The question is, why would you want to do it? And there's a couple reasons. One is you're a nerd at heart, which you're in the medical field, so by definition you have some science interest, and you probably have a little bit of a nerd in you. It's interesting, that used to be an insult, but now I have a 9-year-old grandson who takes it as the ultimate compliment when someone calls him a nerd. So times have changed. You want to advance medicine. There's a certain amount of prestige involved in it. If you really want to have the King of Sweden give you a medal, this is, one of your personal aspirations. Unfortunately, I didn't get invited this year either. So, I guess unless somebody wants to give an award for writing a case report about bariatric patients on a CAT scanner, I don't think I have much shot at this in the near future. There's prestige for your department, whether you individually or a number of members of your department publish something. There's a certain amount of prestige that goes along with that. And then the hospital gets some prestige. There's financial reasons to do it. If you can set it up and you become involved in a sponsored study, either by a drug company or device maker or something like that, there is a fair amount of financial reimbursement for you and for the institution. So if you get involved in one of those studies, they will pay you as a investigator, but they'll also pay the institution. So there's prestige there within the hospital because you're bringing an additional revenue stream into the hospital. The most important reason to do this is what's called the teacher's paradigm. And it goes like this. All of us have been through 8, 10, 12 years of education. And inherent in that is this respect and admiration for your teachers. Now, you may think a teacher's a jerk, but you still had to defer to them that they knew more than you. It's just ingrained in us, pretty much starting from grade school on. And it doesn't matter whether you're a wizard or you're a clinician. You defer to the teacher. And once you start becoming the teacher, particularly in your institution and to your medical staff, it creates a whole different way that they look at you. Okay, so you really can wind up intimidating the medical staff. And it doesn't even have to be on the topic that you've written on. So if you have a reputation for having published an article or two about a specific subject, when the cardiologist comes down to talk to you, they talk to you at a different level than if it was just them coming down to talk to you as the emergency medicine clinician. Now you are the emergency medicine clinician educator. And it's just different because these guys are still going to CME classes and those types of things. And again, it's still inherent in them to defer to the teacher that they just know a little bit more to them and it's a little bit more respect. What do? Well, there's a whole lot of things. We're going to talk about there's textbooks, journals, medias. There's all kinds of ways that you can get yourself published or at least in the press and in the position where you are now the educator that other people have to look up to. So what are some of the things that you can do? Well, what I'm going to do is I'm going to go through a bunch of things that we've done. And these are just examples of things that we did that fall under the general umbrella of research. A lot of it are just simple publications. But these are things that we did at a community hospital with absolutely no research budget. So we had no research budget, no grants, no nothing. This was all done just on the, I guess, the free time of the clinicians there. And we'll go through what we did and how we did it. And these are just examples of what we've done. So one of the things is just do retrospective type studies. Go back and do a literature review. This was a respiratory support for adult patients with COVID. And we just got tagged on to this. That's actually Jess Whipple did most of the work on this. But the bottom line is these are easy to do. You basically wind up looking at some of the literature on a subject and summarizing it and put it out together in a summary article. And these get published very easily. The nice thing about this is the shorter a disease has been around, the shorter the amount of literature on it and the easier it is to get something published. So if you're going to do a retrospective literature review on endocarditis, you're going to have hundreds of articles to go through. If you want to do it on COVID, not that many articles out there early on that you could go through on this. You may get asked to do an article on a really narrow subject, and this is a great one to do. The people from Pediatric Emergency Care say, hey, you guys have a bariatric program at your place. Could you write an article on the care of the post-metabolic and bariatric patient? I was like, yeah, there's not that much written on that. I mean, and it was interesting when you look at it, the dozen articles written on it all had the exact same thing. So they're easy to summarize, easy to write. So these things are easy to do. They get you in the press. And the interesting thing is when this article came out, all the bariatric surgeons in the health system were writing a little note like, oh, this is wonderful. You got the name of the health system in print, and our bariatric surgery program is going to benefit from this. So there's a prestige portion of this as well. But the hospital liked it. So again, you're looking to change the way the hospital and the medical staff looks at you. This is one easy way to do it. If you're really into statistics, you can do a meta-analysis, and a meta-analysis is a lot more involved than a literature review. And the meta-analysis means basically you look at a bunch of studies that were done, and one study had 30 patients, another study had 60 patients, another study had 100 patients, and you take and you add all those patients together and do your own analysis on them. This is pretty challenging to do, and you need to have a pretty good basis in statistics to do it. But it's an easy way, though, to get a publication done if you are so inclined. There are people who are very, very good at this, and they just built their entire CV around doing these kind of things. This is a slam dunk easy one. These are chart reviews. And here what you do is you take something that you guys do a lot of. We do a lot of transvenous pacemakers. So what we did is we went back and we got from the hospital's billing office all the people who got billed for a transvenous pacemaker in the emergency department, pulled all those charts, went through them, looked at what happened to them, and then just put it together and said, okay, let's publish what happens to people who get transvenous pacemakers in the emergency department. These types of studies are very, very easy to do. Find something that you do a lot of or that you do well, pull the charts, describe your experience with them, describe your outcomes with them. And these get picked up very, very easily. And the best thing about this is something that you can kind of slip into your performance improvement committee, like where everybody else is counting the number of times someone forgot to sign the discharge summary on patients and putting PI reports together like that. You then put together a report like, oh, here's our latest PI study. And by the way, here's the publication of it. Which again raises quite a few eyebrows in the department and in the PI people, because now, in addition to just doing the typical bean counting that you see at these PI meetings, now what you're doing is like, hey, our PI is actually advancing the practice of emergency medicine. So they're easy to do, and these are things that really raise the eyebrows of the people in the PI committees. Retrospective studies with the electronic health records. These are probably the most simple ones to do because you've got all this data sitting in your electronic health record, and just go in and snoop around and find something. This was a study where we said, hey, you know what? Let's look at how well the physician assistants and the nurse practitioners are performing in the rebound visits for pediatric patients. So we went in to the electronic health records, got a download of all the children under 6 years of age that were seen in the department, who got seen by the PAs, who got seen by the attending, who got seen by both. And then looked at the number of revisits within 72 hours. Basically, a lot of just counting up numbers and doing some percents, and then put it together, and we're able to show, well, gee, the results of it were pretty straightforward, that the physician's assistants actually did a better job than the attendings in not having kids bounce back to the emergency department. But it was a really worthwhile study, and it had some value in the department in terms that it reinforced the fact that our advanced practice providers, the PAs and the nurse practitioners, were able to deliver care that was comparable to the attendings in this area. But in terms of what you're looking at, the EHR's got a ton of data in there that you can just pull out and look at. And one of the easiest things is actually the rebound visits, the revisits within 72 hours. And you can compare different things like, gee, I'd like to look at the number of revisits of people who are seen in the morning compared to people who are seen later in the day, the number of revisits people seen overnight versus the middle of the day. Nobody's done that. So if you're so inclined, just go look into your electronic health record. You can do this pretty easily. You can hospital snoop the data. This looked at some charges for patients who are cardioverted and discharged from the emergency department compared to those admitted. And again, just go to the hospital and say, I would like this data. It's generally nice to get somebody in one of the other positions at the hospital to join in when you're doing these kind of things, either the one of the VPs or an administrative of some type, because they're always into looking at cost and everything else. And this is a nice thing that says, hey, look at this. The emergency department is much more cost effective than the rest of the hospital. This is one other source of things. We did this with Aileen Holmes from the New Jersey Hospital Association. And this was they have a ton of data. If you go to the New Jersey Hospital Association, they have tons and tons of data on every ED visit in the state by every hospital. So you can go in there and just say, hey, can you give me a download of all the ED visits for children under 10 years of age who had a CAT scan, which is basically what this study looked at. And they'll give you that downloaded data, and they'll give you the hospital that it's associated with. And then you can look and say, oh, gee, is there a difference between the community hospitals versus the university hospital versus the children's hospital versus those types of things? So there's lots of data on the state level that you have. This is a study from a manuscript that we have, we're finishing up. And what it looked at was just very straightforward. The number of emergency department visits, this is the red line is the adults, the green line is the pediatrics, and the blue line is the intubated adults, or I'm sorry, the admitted adults. And the purple line is the number of COVID cases in New Jersey during those particular times. And all we do is stick them all on an Excel sheet and plot them out. And you can see there down the bottom, the initial surge in COVID patients that we saw back in the spring of 2020. And you could see, if you look at the red line, it's the easiest one to look at, the big drop in ED visits that you all knew about. Then you see our visits start to come up. And now there's a second surge in the COVID visits, and you can see the number of cases going down again. This is simply a matter of getting a download from your EHR of the number of patients you're seeing on a daily basis, and map that against the download. Just go to the CDC's got all the data on the number of new cases of COVID in the state. Just plot them against each other, and there you go. You've got something unique out there. Nobody else is looking at specifically matching ED visits to number of COVID visits. And then case reports. You see something interesting, it's always nice to take a look around, just kind of quickly do a Medline search and say, hey, has anybody ever reported this? This was actually one of the more interesting ones that we did. It was a gentleman who was wearing a Fitbit and went into AFib, but he couldn't tell when he went into AFib. And we were able to go in and look at the Fitbit and say, oh, you went into AFib like 4 hours ago. So he was able to be cardioverted discharged. These are the kind of things, like something unique happens, or you did something interesting with somebody, and these are the results that you had. Nobody thought about it before. That's worth a case report, and it's worth going ahead and writing it up, because a lot of these case reports turn out to be the basis for subsequent prospective studies and whatnot. So you may be the one that kind of introduces a novel idea with what you thought of when you did a case report, and then that turns out to be the nidus for some very major studies. Prospective stuff's a whole lot more difficult to do. What you can do in the community hospital that's pretty easy is these observational studies. So say that there's something in particular that you do and you see a lot of. So this is we see a lot of dialysis patients, and as a result, we wind up putting it's a button that you actually sew onto a leaking dialysis graft when they show up in the emergency department. Well, what we did was we just put the word out to everybody. Hey, listen, whenever you see one of these patients that comes in with a leaking dialysis graft that you sewed a button onto, just write the name down and give it to me. So you're prospectively collecting the patient's information, and then you just pull the charts and you can collect whatever data you wanted to collect on them, and you write it up. Basically, like, hey, we saw a bunch of people with leaking dialysis grafts. We sewed this button on and it seemed to work pretty well. That's basically what the article says. But prospectively, those observational studies are easy to do. in the emergency department. Just let the folks know that you're interested in them, and you can collect them. What's way more difficult to do, and you need an infrastructure for this, is randomized controlled trials. And these are the ones where it's, okay, we want to compare colchicine to prednisone in the management of acute gout in the emergency department, because now you have to get consent, you have to enroll all these people prospectively. You're going to have to go through the IRB for these. And you need an infrastructure because you have to follow all these patients for an extended period of time. So these are things, if you're going to do that, you need to piggyback with somebody else. It's very difficult for an emergency department to do this on their own. There are a number of community emergency departments in the state that do get involved in these. I think that the best one would be Morristown Memorial's got a very robust research program, and they've got the infrastructure for the people who follow patients long-term and get involved in these studies. But these are pretty much kind of out of the realm of most general emergency departments that are community-based. This is one other thing that's very easy to do, and that's it if you like to create models. This is where you basically go into your computer and you say, okay, let's see what happens if I build a small community, and in that community model, I put this disease in there, and I say it gets treated well here, but it doesn't get treated well here. And then what happens if I move some pieces around? What happens with the model? This was basically what happens if you change the way pediatric emergency physicians are set up in the community. Instead of centralizing them all at the tertiary care children's hospitals, you spread them out in the community. What happens to the way the kids are managed? And that's just done on a computer model. So if you have a little bit of computer programming ability, these are easy to do. And again, this is where you can really set up models where people can then do prospective studies to examine what you modeled. So you can model things along the lines of, what happens if I change the time from arrival to clot extraction in a large vessel occlusion stroke from 60 minutes to 90 minutes? Does that change the outcome of the patients? I'm going to create a model that'll do that. And I'm going to assume I see so many strokes a month. Then you play with those numbers and come up with a conclusion like, well, if you don't see more than 15 large vessel occlusions a month, it doesn't make any difference. So these are models you can create, and they're very, very easy to do if you have a little bit of programming skills. Moving away from the journals and the kind of research types of things, other things that you want to get involved with, which again will carry the same type of medical staff intimidation that you want, are things like textbooks. Again, if you write the chapter in a textbook, you are the teacher, and again, that carries some weight with it. This is Hardwood Nuts. It's got 398 authors in it. So there's ample opportunity to write into textbooks. And usually the way that happens is, and the way I got my opportunities here, is somebody was an editor or something in the book, and they come to you and say, hey, would you be interested in writing the chapter? And it's usually the chapter you're going to get nothing exciting. They're not going to have you write the chapter on ECMO in the emergency department. You're usually going to get it something like, would you like to do the chapter on paronychia in diabetics or something like that? But that's your start. I will tell you, whenever I get asked to do this, my first reply back is, hey, what other chapters do you need? Because I got my opportunity strictly because somebody gave it to me. And so I whenever I get this, I'll usually turn around and say, what other chapters do you need an author for? And then I'll just put the word out there. Does anybody want to write a chapter? Periodicals are the same thing. These guys need it even more. So things like emergency medicine practice, emergency medicine reports, and whatnot. They're always looking for people to write articles for them. So again, if you're interested, you can actually write the editor-in-chief of these things and say, or if you look at the editorial board, just say, hey, I know this person, or I know somebody who knows this person, and just drop them an email that says, hey, I'm interested in writing an article for you. Is there anything you have that needs this? And I guarantee you will get overwhelmed with, oh, we need these 6 chapters to write. This is, I just literally got this last week from Emergency Medicine Practice when you were just looking at. They need authors to write articles on these topics. So yeah, by all means, this is the type of thing where they are looking for authors, and writing here is pretty prestigious because this is a difficult periodical to write for. But writing for this is very, very valuable. And the nice thing about it is they'll give you a mentor to help you work through it. So they'll work through you with it if this is the first thing you're writing. Getting involved in the media is pretty much the same now as publishing anything. You can write blogs if you're into that, if you know how to set up these kind of things. Blogs are frequently quoted now. So if you've got a blog site and you and a bunch of your buddies get together and decide to put Rebel EM together, well, what happens then is people begin to quote articles off of here, and you can certainly download the articles and send them to people. And if you're the editor, you get to send requests out to your buddies, who then send out requests to their buddies. So you build up a really robust network of things to publish. And blogs are easy to do. No one's going to tell you what you can and can't do. But if you write a respectable blog, you've got references and whatnot. Rebel EM has about 30 editors. So if you're interested, just go to the website, look up any of the people, see if you know any of them. If not, shoot an email to one of the people and say, hey, I would like to write an article on something that you're familiar with. You should always start out writing with what you know. So if your department sees a lot of something, then you say, I want to write an article on this, or I want to write an article on a new therapy that's not working in the community hospital. So those kind of things, these people will jump on right away. And pretty much this is the equivalent of writing a case report or a literature review in a regular journal. Podcasts, if you like to do podcasts, these are great. This is Ryan Stanton runs one for ACEP. You could always write to him. He's always looking for people to interview. And if you do an interview on the podcast, that's great. Or again, if you want to set up your own podcast, there's, the sky's the limit on those types of things. And then you just start interviewing people. Videos, it's real easy to just go to YouTube and set videos up. We began filming different procedures. People love to look at how to do things. So if you want to do like, hey, you know what? We are really see a lot of facial lacerations, and we've gotten very good at repairing them. You can put videos out on, how to do them. Or, gee, we've decided we're going to start cardioverting people and sending them home from the emergency department. You could put videos up on that as well. If you put a good video out there, particularly a procedural video, you'll pick up a lot of followers very, very, very quickly. So again, it's getting your name out there. One of the things is, how do you do this? You can do it individually, with a team, with volunteers, students. What we wind up doing a lot of is getting the staff to help us. For example, if we have a retrospective study that we're doing, there's usually one or two nurses who are working for their master's degree who say, hey, I'll help you pull the articles. I'll help you, collect the data. And then the payback is you put their name on the article. You can even put their name as the lead author on the article. This gives them a publication, which they need to finish their degree. And it helps you get some publication out there, because part of it is it's very, very difficult if you don't have a financial stream to pay people to do this. But it's so much easier if you've got other enthusiastic people in your department. We've had technicians wind up with as co-authors on papers, a lot of nurses working on advanced degrees, and young attendings who are just working on things. So the other option is formal co-investigators, and these are usually things where you're doing an industrial study or something along those lines. Or if you are a member of ACEP, and ACEP's pediatric section is now going to do a white paper on a particular topic, if you're a member of that section, you can volunteer to help work on that, in which case you will get your name on the publication as well. And again, you're looking to get things in print that you can point to the rest of the hospital to say to them, hey, look at, I'm a little different than just a pure clinician. I'm an academician. I'm a teacher. And that makes a big difference in the way you are respected there. In terms of cost, most of this is done with sweat equity. The retrospective stuff, the prospective observational stuff, there's really, you can do this without any income. It's just a matter of your time. You're going to dedicate your time, and you're going to get donations of time from the people who are helping you. The randomized controlled trials, you are going to need funding for that. There's just no way around that. You need the infrastructure for that. So, the randomized controlled trial to determine the efficacy of nutraceutical versus control as a non-antibiotic prophylaxis. But who the hell is going to even read this article? But these guys, put it out there, and they got funding for it, and they're all excited, and they showed the publication to their moms and stuff. But the reality of it is, you need an infrastructure, and that costs money. Okay, and this is just the way that's set up, and it's just very, very difficult to do that without having some people you can pay for it. Now, the other thing in terms of that is, like I said, most of what we're going to do, and most of what's going to be done in a community hospital, is going to be done with sweat equity. You're offering an opportunity for career advancement for their contribution to the study. One of our PAs wanted to move more into academics in the physician's assistant, and he said, look, I'll help with this droperidol study. And so he did a lot of the heavy lifting on this thing, pulled the charts, went through them, looked for all the complications and whatnot. And in return, he got lead authorship on this, which then gave him a publication that he could cite to move on. So a lot of times, if you're looking for co-investigators and whatnot, you don't have the funding to pay them, but you're going to be able to advance their careers. Grants are out there. If you've got a very astute grant office at your hospital, they're there. People get them. John Brennan, when he was the CEO up at Newark Beth Israel, had a really wizard of a grant officer who was able to get him grants all the time. So they're there, but it's a real challenge. You really have to have somebody who knows what they're doing to be able to write a grant. And most of you remember back to your residencies, every time you walked in to visit one of the professors, they were saying, oh, what you doing? It's like, I'm writing my grant. So yeah, it's a time consuming process, but it is a way to fund the things, but you really need some help with that one. And if you're going to work with an industry, either a drug company or a device company, they'll provide the funding for you there. But again, you've still got to build the infrastructure. In terms of methodology, there's lots of things out there. You don't have to worry too much about that. This is the only thing that is worthwhile looking at. If you're going to do a retrospective study, this is something that's worth downloading and reading through, because the last thing you want to do is put 50 hours into a retrospective study and send it out for review and have somebody just send it right back to you and say, listen, you didn't even come close to meeting our standards. So you want to make sure you're on board. And this is the one study that everybody quotes as to how to do a retrospective review. The other thing is, if you're looking, you've got an idea, you've got a topic, go and look at clinicaltrials.gov, because you don't want to be reinventing the wheel. So if you look and you say, hey, I really think I've got a great idea on the best way to treat recurrent MRSA infections on people, go and look in here to make sure that 5 other people haven't already done that study or aren't doing that study. So you might want to take a peek in there, because you don't want to spend a lot of time and effort doing something only to find out that you've reinvented the wheel. If you got someone who's got some experience, or somebody, certainly work with them. Everybody who does research is more than willing to help you. Give it a try. If you've got an idea, you got no downside to giving it a try. This I gotta kind of emphasize. You will get disappointment. This is the 7th rejection letter that we got from a study that I thought was absolutely a slam dunk. This was New England Journal worthy study. And you usually get a letter something like this: thank you for submitting your manuscript, you dumb shit. Based on our editorial evaluation, we were laughing at what you sent us. I regret to inform you that we will not consider your article, and if we ever see your name come across our desk again, we're just going to trash it. These things cannot be always pleasant. Sometimes, and more times than not, they will try and ease you down, and they'll usually have a line that says, you know, it's not that your work isn't worthy of publication, but we receive so many outstanding research articles. It's like, yeah, that's, you're just trying to make me feel good. You didn't like it, just say it. We didn't like it, send it back to me. But if you send it around enough, you can usually find someplace that will publish your research. What I find is if you submit it to the Goofus and Gallant section of highlights, it usually gets picked up. And I would venture to say that looking at the age of some of the people that are now in ACEP, particularly New Jersey ACEP, most have never even seen a highlights magazine. So it's something, Google it, it's something worthwhile. Google Goofus and Gallant while you're at it. Where can you publish? Print journals, open access journals are easier to get things published in, although you got to be careful with the open access journals, particularly the tabloid types. You probably have gotten emails that said, hey, doc, you know, why don't you think about publishing your research in our publication? And they will publish it. They will publish a lot of things. The downside to it is they'll publish it and then they'll charge you $5,000 to $10,000 to publish it. So you want to be a little bit careful when you look at those types of options. All right. The only thing I will tell you is you never know until you give it a try. If anybody wants to, you've got my email address here. If anybody wants to send me an idea, a draft or anything like that, I will be more than glad to look at it. Like I said, you know, the only way I've gotten anywhere in my career is by people giving me opportunities and options and giving me a hell of a lot of support. So I will be more than glad to look at anything anybody wants to send out there. One thing I didn't mention is there is an IRB, an institutional review board at every site. Make sure that if you have an idea, you run it by them. Some places are very loose in terms of, yeah, if you're just looking in the electronic health record and counting the number of patients who have, you know, MIs over a period of time, and you're not collecting their names or addresses or anything like that, that's fine. Others are much more stringent, and you'll have to do a formal IRB application. So that make sure you check into that before you start down the research path there. All right, Janice.
Thank you, Al. Thank you very much for that overview of how you can get into research through community emergency department work. There is one question that asked, would you please tell us briefly how are multi-center research projects initiated and conducted?
The multi-center trials are usually a good old boy network. There is somebody who's worked with somebody else who's worked with somebody else, and what you usually find is somebody says, oh, I'm going to do a study on such and such, and they ask all their friends to get involved. That said, if you keep an eye on things, there are certain societies and certain subsets in societies. For example, ACEP is very, very good at this. Their geriatric section, Chris Carpenter, if he wants to do a study, he puts it out there on the section and says, hey, we are thinking of doing this, in which case you get involved. You'll get an opportunity to invite yourself to write back and say, hey, you know, our department sees a lot of geriatric patients. We want to get involved in that study, in which case you'll then start a communication with him. Other multi-institutional studies, again, when we've done some of them, it's been, I know Chris up at Morristown and you know, Robert over at what's the name, Virtual and whatnot, they're interested in this. Let me just ask them. So part of it is that way. But if you're involved in ACEP and particularly a section of ACEP, if they're going to do a study, they will reach out and invite you, or they'll offer the opportunity for anybody in the section to become involved in the study. And that, Janice, that also goes not just for the multi-institutional, you know, prospective studies, but if they're going to write a white paper, so say one of the sections going to write a position paper on something, they will say that, okay, the section's going to do this, in which case you have the opportunity to join them. ACEP's very, very welcoming in that respect.
Thank you, Al. And one of the things you mentioned about funding or resources that made me think about how I got involved with New Jersey ACEP and actually started applying for grants through New Jersey ACEP. So that's also a good place where you can start and go through and just kind of see on a smaller level what the application can be like, and that might get your feet wet. And then you can apply for other funds of resource funds for funding for research outside of ACEP.
I think, and
Go ahead.
right, I just going to say, Janice brings up a really good point, because if you look at the age of the people of New Jersey ACEP and New Jersey ACEP's board, these are all young go-getters, and they've done things that in my generation weren't done until you saw people in their 50s. So staying involved with New Jersey ACEP and watching what they do and getting involved in those things, like Janice said, getting grants from ACEP. Now, pretty much anything you get a grant from, you wind up turning into a publication of some type. And so there's a lot about it, because you have to do the research before you can do the publication. But so many of the grants, and particularly Janice's studies and what she's published, all of that spun off of initial efforts in an area where she got together with people with other areas of interest or got particular grants and looked at that. And those publications really changed the way you practice more than anything else.
So we have another question. Great talk, Al, from our current president, Steve Hockman. He has a question on the transvenous pacer study and other retrospective chart reviews. The challenge is follow-up for outcomes of patients years later. How did you do this and how successful were you?
Yeah, that's we were able to pull this off only because in Camden, there's a health information exchange that included all the hospitals. So you could literally go into that and look at the follow-up visits for it. And the people said, well, is that a HIPAA violation? It's not a HIPAA violation if you were involved with the care of the patient and you're looking for follow-up to see if you did a good job. So that's not a HIPAA violation. It's a HIPAA violation if you're deciding whether you're going to give health insurance to somebody and you're searching the database. But it's not if you were involved in the care of the patient. So we were basically looking for follow-up to see if what we were doing, once they left the emergency department, were these people then having problems as a result of what we were doing. So it was purely a medical indication. So you can do that. That's not a HIPAA violation. But if you're just kind of snooping around to see what kind of health history people have, then that's a problem. Not having access to the Camden Health Information Exchange, it would have been impossible to do this study other than to see who came back to our particular institution. So that becomes the issue there. So yeah, it can be more difficult. Now, the other thing that's totally reasonable, Steve, is for you to collect the name and just call the patient and say, hi, I'm following up on your visit with us. If you're going to do that, you probably want to advise them in advance that we're going to talk to you and let them know. And that's when you really do have to go through the IRB and say, we are going to tell people, we're going to call them and do a survey on them after they are discharged from here. So that one, if you're going to do it prospectively, you need the IRB. But if you're doing follow-up and you have some way to track them down and you just are looking to see how well you performed, that's just good care. I mean, it's no different than calling people up 2 days after their ED visit to see how they turned out.
No, agreed. I appreciate that. The problem is, like, if you're in a catchment area like ours up in Patterson, people can go anywhere from West New Jersey to South to New York City. And then sometimes, as you know, the phone numbers that we get aren't good. So a year or two later, which would be what your interest is, with something like, that's not that common, can be challenging. So, I mean,
absolutely.
Your follow-up rate is everything there, because they could have been lost to follow-up and they could have died, right?
Absolutely. Oh yeah, that was one of the big things that took us the longest thing. The longest part of that was going through and tracking people down for that. But yeah, if you're going to do that type of thing, especially in your neck of the woods, that's going to be really challenging. Now, some people have said, if Epic has a a research arm that does have a way to track people. And again, you're gonna have to go through the IRB on that one. But Epic does have something that allows them to track people if to any other institution or hospital or office visit who's got a an Epic record. So if you're involved with Epic, I know they have a research arm that lets them do that.
Thank you.
Thanks.
We have another question by Victor Almeida. Is the Hospital Association willing to share data by just asking? I see Aileen Holmes is online. Maybe she can help answer that question from the Hospital Association.
Yeah, if Aileen's online, she was the lead author on the study we did. And yeah, she's the one who told us, yes, we have this information, and it's the Hospital Association is very interested in looking at those kind of things. We were tracking CAT scans on pediatric patients. And to the extent that they can, the spin-off of that was to then create a bunch of posters that said, okay, these are the indications for the CAT scan, so you could subsequently lower the use for it. I don't know, is Aileen, are you on? No.
May not be able to come or unmute herself at the moment.
Yeah.
There's another question. Is there a way to determine which journals publish PI studies? Do journals have a PI study subsection? Do you know of journals that are more favorable to PI studies?
Sure. What you want to do is, if you go into any journal, it has there's a section called author instructions, and it'll tell you the type of things that they will publish. And then you can go back and look at some, and they'll have examples of previous issues. If you go back and look at previous issues, you can see that, for example, the New England Journal of Medicine is not going to, publish a study on wound infections in dog bites in 40 kids in Camden. But there are infectious disease journals that might be interested in that. So what you do is you look in the section where it says author's instructions, and it'll tell you what all the different areas they will publish in. And some will say we do this kind of stuff. Some will say we don't. For example, the Journal of Pediatric Emergency Care used to have a whole section on case reports. They've recently dropped off their section on case reports because they said they had too many other articles that they needed to get into the journal. So you want to look in the instructions for author section. That'll tell you exactly what you need to know about that.
Great. And another comment that one of our listeners, Greg Neiman, mentioned is that possibly we can all be a resource to each other, the individuals who have joined on. He stated he's good with coding and can help model development. So it just prompted an idea that perhaps on our New Jersey ACEP website, we can have a link for those interested in research or Research Basics 101, and individuals who are interested or helpful for one type of skill set or another can start there, as this could be something new for someone.
Yeah, I mean, if he's good with coding, and models are really easy topics to pick out, and because instead of like Steve had said, it's difficult to do these retrospective studies and trace people down. But what the model you can do is you can model 5 different treatments of something and do it in a matter of hours versus waiting for 5 different episodes where you enrolled all these people and followed them out. So I think somebody who's good at computer programming and modeling, that's a great way to get some ideas out there. And the interesting thing about the modeling is once you get them introduced and the models out there, a lot of people say, you know what, let me now turn around and take your model and try and apply it. And that's actually happened in New Jersey with the EMSC. We had done the model, which was decentralizing pediatric care, and then basically wrote the regulations and set the EMSC model in New Jersey that was a non-centralized model. So it's always interesting to do those kind of things. I also like your idea, Janice, where it's using New Jersey ACEP as a resource for other people. So if someone says, I've got all these cases I saw, but I don't know how to do the statistics on it, somebody could say, oh, I can help you with doing the statistics on that. Or someone says, I've got this data, but I'm a really terrible writer. Someone else can say, okay, I'll help you write this thing, or I'll write the thing with you and be the co-author. So taking advantage of the skill sets of all the different people that are in ACEP, and I think is worthwhile. So, and people like you and Steve and whatnot who have applied for all those grants. Well, that's a skill that's really, really valuable. And that people in New Jersey ACEP should take advantage of.
Any other questions?
My one suggestion, just to add to what Al said about grants, is that don't bite that off if you are ready to chew on it, because that is a massive, massive, massive amount of work, like more work than I think I've ever done on anything. So it's great if you can get money, if you have a source of money. It's just there's so much stuff that you got to do. You really need a good team and you need some direction.
Yeah, I think Steve's point's really well taken. You need a team. I remember just everybody I'm always talking to. It's like, hi, what are you doing? I'm working on my grant, type of thing. So yeah.
Yeah, we'll leave you alone for a couple of months.
Yeah. Yes.
Well, if there aren't any other questions, Al, we just want to thank you so much for sharing your wisdom on this topic. I think it was well received, and I am very happy that you were able to be our second speaker for our leadership series.
Thank you very much for the invite.
Anyone else who's listened or have other ideas or questions or things they'd like to hear, you can put it in the chat box or email us. We want to make sure that we're meeting the interests that the group has. Enjoy the rest of your Wednesday.
Thanks, guys.
Janice, it's Dr. Almeida. I would just say that maybe there's over 50 people that are on this. Maybe that's something that for New Jersey ACEP, having developed that skill, and that we should, as New Jersey ACEP, have a research arm.
Yeah, I like the idea. Yeah.
And that would be the mentorship idea, which would probably be great. I'm not aware of anybody else doing that.
Or any other chapters, yeah.
Right, exactly.
Yeah,
and then taking that forward.
Mm-hmm. Like a research 101 for New Jersey ACEP.
Yep.
Mm-hmm. It
would be great. It would be good to promote collaborative research, right?
And you can even start it, because we have med students and residents starting it early on, as well as those who've been established, even working together. I think it's a great way to think of about a different side of your practice, right? Not just bedside.
And it's for the community hospital doctor rather than maybe the folks that are at the academic centers.
Mm-hmm.
Yeah, I think the folks at the academic centers have ample opportunity to do it because it's built into the academics. But I think you're absolutely right, Victor. The community hospitals, because that's when you really think about it, most of the studies that really impact what we do come out of community hospitals. They don't come out of the big academic centers.
Mm-hmm. Yeah, interesting. I'm going to send you an email, Al, and to Aileen, and we'll see.
Yep.
All right, everyone. Take care.
All right. Thank you.
Right. Yep.
Great.
Bye-bye, guys.
Be safe, everyone.
Take care.